Cummings, Audiology, Section 2, Diagnostic Assessment, Chapter 134, Diagnostic Audiology and Electrophysiologic Assessment of Hearing. Electrocochleography. The term electrocochleography, ECOCHG, refers to the measurement of neuroelectric events generated by cochlear structures and the auditory nerve in response to acoustic stimulation. Depending on the mode of stimulus delivery, the ECOCHG response may consist of the cochlear microphonic CM, the summating potential SP, and the whole nerve action potential AP generated by the auditory nerve. One of the main clinical application of ECOCHG is in the differential diagnosis of hydropic conditions of the cochlea that may be associated with Meniere disease or other diseases. It is believed that the presence of hydropes affects the elasticity of the basilar membrane and contributes to the increased amplitude of the summating potential relative to that of the action potential. A relatively large SP bar AP ratio is considered diagnostic of endolymphatic hydrops. The SP bar AP amplitude ratio is used instead of absolute amplitude of the SP to avoid contamination of this measurement by interpatient variability. Thus, patients with endolymphatic hydrops are thought to exhibit relatively large SP bar AP ratios. In one study, SP bar AP ratios measured for subjects with normal hearing for their age were found to range from 0.04 to 0.59. Gibson and others reported transtympanic SP bar AP percentage ratios that range from 10% to 63%. Coates and others found that 44% of ears considered to have Meniere's disease fell below the 95% upper limit values for normal ear. Figure 13.134.6 transient evoked autoacoustic emission A and distortion proportion dP autoacoustic emissions B from the same normal hearing ear. dB SPL decibel sound pressure level. Measurement of these events requires an electrode placed as close as possible to their source. The components of the ECOCHG response are most prominent when recorded directly with an electrode placed on the round window. Because this requires surgical exposure of the middle ear, it is not widely accepted for routine outpatient clinical application. An alternative method is used of a transtympanically placed needle electrode referred to as an electrode external to the ear, forehead, or tragus. Other less invasive recording techniques are also available that include the use of electrodes. Example, the Coates leaf electrode, a gold foil wrapped foam plug, or a tympanic membrane surface electrode placed in extratympanically in the external ear canal. The tympanic membrane surface electrode is gaining in popularity because of ease of placement and the clarity and amplitude of the responses it provides. One type of tympanic membrane surface electrode consists of a hydrogel tip that encases a silver wire threaded through a soft polyethylene tube. This electrode is positioned gently over the lateral surface of the eardrum under microscopic visualization using with a small nasal or Lampert speculum to avoid dislodging the electrode as would be in case the case if a standard ear speculum were used. Although the amplitude of the response obtained with the tympanic membrane surface electrode is attenuated compared with the trans-tympanic needle recording, its ease of placement and non-invasive nature make up for this disadvantage. Figure 134.8 illustrates an ECOCHG response recorded with a hydrogel tympanic membrane surface electrode. This response was elicited by an alternating click presented at the level of 85 decibel NHL and clearly consists of a well defined SP and AP. Gibson evaluated the use of ECOCHG in diagnosis of Meniere's disease and suggested that measurement of the absolute amplitude of the SP from responses to 1 kHz tone burst stimuli was optimal. He considered an SP with an amplitude in excess of 3 millivolts abnormal. Margolis and others used tympanic membrane surface electrodes and provided detailed statistical information on the click evoked SP-AP ratio, the latency difference of the AP when elicited by condensation versus refraction clicks, and the absolute amplitude of the SP from the response to 1 and 2 kilohertz tone burst stimuli. This was a normative study that involved 53 subjects. The authors found mean SPAP ratios to be somewhat dependent on stimulus level, ranging from 0.22 to at 78 decibel normal hearing level to 0.29 at 68 decibel normal hearing level. Ratios in the 95th percentile ranges from zero point 0.4 to 0.49. The authors also determined normative ranges for absolute SP amplitude from responses to tone bursts by use of criteria of 0.35 or less for a normal SPAP ratio and zero point 0.5 or larger for a definitely abnormal test. Poe and others found that 57% of patients were clinically diagnosed endolymphatic hydrops were correctly identified. It is figure 134.9 illustrates an electrocochleographic recording characterized by an elevated SPAP ratio more than zero point 0.5 obtained from a patient with Meniere's disease. The following case illustrates the utility of ECOCHG in the management of the patients with Meniere's disease. A 51-year-old patient has been followed in our department for the past 7 years. She initially presented in our clinic with a complaint of episodic vertigo, fluctuating hearing loss, oral fullness, tinnitus, and subjective hearing distortion in her right ear. Her right sided fluctuating hearing loss has been well documented with low frequency thresholds that vary from 20 to 60 decibel and values in between. In addition, she also presented with a stable high frequency hearing loss in her left ear. The audiogram in her left ear also has demonstrated stable hearing with slightly elevated low frequency thresholds, normal in the mid frequencies, and a mild high frequency hearing loss. She was treated conservatively with a low salt diet and diuretics with which she was compliant. However, her hearing thresholds continued to fluctuate and she continued to experience episodic vertigo in addition to rather frequently sensation of impeding attacks. After 7 years of these symptoms, it was decided to treat her with a right sided labyrinthectomy because her hearing loss remained consistently in the moderate range with rather poor speech discrimination 52%. However, prior to undertaking the operative procedure, it was important to confirm right sided eye drops by ECOCG and more importantly to rule out eye drops in her left ear to avoid ablative surgery in a potentially bilateral case of Meniere's disease. ECCHG was carried out utilizing a combination of surface electrodes and tympanic membrane surface electrode introduced under microscopic visualization. The tympanic membrane surface electrode consisted of a hydrogel tipped tympanic electrode TM electrode for electrocochleography, Sanibel supplied Denmark. For optimal recording, the hydrogel was briefly dipped into conductive electrode cream and was inserted into the external ear canal using a small nasal speculum and the otos microscope. It is important for the hydrogel end of the electrode to make contact with the tympanic membrane. The electrode is then secured in the canal using the compressible foam tip of the inner insert transducer used to deliver the auditory stimuli to elicit the response. Figure 134.11 shows the result of the electrocochleography evaluation. Illustrates a two-channel recording protocol. The upper trace is the electrocochleograph recording utilizing the tympanic membrane electrode. The lower trace is a contralaterally recorded ABR. In this manner, in this manner, it is possible to simultaneously record and evaluate ABR as well. With stimulation of the symptomatic right ear, a prominent SP was noted, and when the amplitude of the SP-AP ratio was calculated, referenced to a pre-stimulus baseline, the ratio for right ear was elevated with a value of zero point 0.5, and the ratio for the left asymptomatic ear was within normal limits with a value of 0.22. These results confirm the presence of high drops in the patient's right ear and did not rule out high drops in the left ear. She subsequently underwent a right sided labyrinthectomy with no complications. At the same time, she also received a bone anchored hearing aid on the right side to compensate for the complete loss of hearing on the right after labyrinthectomy. This patient was followed on in our audiology clinic for several months after surgery, and she was found to be completely free of her previous vestibular symptoms. Thank you.